Welcome to PEM Chat. This is a peer-to-peer educational podcast about pediatric emergency medicine for the advanced practice provider. My name is Toni Dobson, and I am located in Chattanooga, Tennessee, and I will be your host. Welcome, everybody, back to the PEM Chat podcast. I'm excited to be here today, and we are going to be talking about an incredibly interesting topic, which is the return of vaccine-preventable illnesses. Now, regardless of what side of the aisle you stand on with regard to vaccinations, the reality is we live in a time when parents are vaccinating less. So the herd immunity that we have known for generations is going to start to wane, but we don't know when. We are currently recording this podcast here. It's January 26th of 2026. And right now, as we're recording, there's an outbreak of the measles in the southeastern U.S. Now, I have never seen the measles. In fact, when I was in school, I learned that we had essentially eliminated the measles in the United States, and yet here we are with a measles outbreak. So as an emergency department clinician, I rely so heavily on pattern recognition and my experience. And I think that's what really scares me about vaccine-preventable illnesses is that I don't have those things to lean on. So making this episode today about how we as clinicians can prepare for the return of some of these diseases has been on my mind for a while, and I was really just waiting for the right provider to cross my path. And then one afternoon, sitting in the ER, I was sitting next to one of our EM residents, Dr. David Wang, and he said, "My mom is a huge fan of your show." And I remembered that she was a recently retired pediatrician. So I thought she might be the perfect person to share with us her early career experiences on managing some of these vaccine-preventable illnesses, and lucky for us, she agreed. So our guest today is Dr. Margaret Wang, and let me share just a little bit about our amazing guest. Meg went to med school at Northwestern in the mid to late 80s, and she completed her residency at Columbia Babies Hospital in New York City in 1990. When she was there, it was actually the epicenter of one of the measles epidemics that they had in 1989 to 1990. She was in practice there until 1996 when she moved to Missouri, and then worked at the University of Missouri, Columbia, until she retired last summer. She has tons of firsthand experiencing managing these vaccine-preventable illnesses that we rarely see today, and she really saw the landscape of medicine change during her career because of the success of vaccines. Not only is she accomplished, but she is lovely in every way. And I hope that today is just the start of our friendship, Meg. So thank you so much for being here.
Thank you.
So tell us something interesting about you outside of medicine.
Well, I have 3 children, and they're wonderful kids. My eldest, Jenny, is a psychologist in California and has a husband, Chris, and a 2.5-year-old daughter, Lola. Michael, my middle one, lives with me and works at Arby's. And my youngest, David, is at Erlanger. He's an emergency medicine resident, 3rd-year resident, and his wife, Michelle, is an internal medicine resident.
Awesome. And we love David. So I'm so happy that he made this connection happen. So thank you, David.
Another thing about myself is I love to read books about mountaineering. I've read about 25 books on Himalayan mountaineering, and I find it really fascinating, but I will never climb a mountain. I just like to.
Yeah, same. There's all these, have you seen the documentaries on Netflix on all these guys that climb it?
Yes, I love it.
I have an internal adventurist as well, but there's no way I'm climbing Mount Everest.
I started with Thin Air by John Krakauer back, many, many years ago. That book is fantastic, and that got me interested in.
That's cool. Do you have experience? Did you grow up camping and doing outdoor stuff?
No. No, I just find it fascinating.
All right. Well, in preparation for this podcast, you sent me a Word document with sort of the history of vaccines and your experiences, and really fascinating to read about. I've told you this before, and I'm going to tell you again, you should really write a book about this because it just kind of brought the history alive for me and kind of put in context some of the stuff that I don't appreciate because I've never seen this. So if you will, paint a picture for us about where the world was when you started in medicine and what a typical shift looked like for you when you were taking care of kids.
Well, when I first started, in 87, the world of pediatrics, we only had 3 routine vaccinations: DTP, oral polio, it was oral at that time, and MMR. So way fewer than we have now. Many diseases had no protection, no vaccination. There were 3 more diseases that were, or vaccines rather, that were available but not yet routine. Hib came out in 85, but it really wasn't routine until about 1990. Hepatitis B came out in 81, but it was just for the quote unquote high risk children. We didn't start the universal Hep B in the nursery until 1991. And then influenza, again, only given to very, very rarely in the 80s, just the very high risk children. It wasn't until 2008 that the ACIP recommended yearly flu shot for 6-month-old to 18-year-olds. So again, just 3 routine: DTP, OPV, MMR.
So without all that vaccine coverage, practicing medicine in sort of the hospital setting, how did that look different then compared to now?
So it was very, very different. Work in the ER, work in the hospital, work in the outpatient clinic were all different in many ways compared to now. I would say some things were similar. If we just look at the ER, we saw many of the same things that you all see: nursemaid's elbow, fractures, asthma, otitis media, all of that was similar, UTIs. But we saw things that are hardly ever seen today, and saw a lot of them. It wasn't rare. Varicella with complications, rotavirus gastroenteritis with dehydration, measles. We saw a lot of measles, and fever. And of course, you see fever today. Kids always have fever. Babies and toddlers always have fever. But what was so different in the 80s and 90s was our approach in the emergency room, our approach to the child with fever. And we had to have a different approach because so many of them had severe bacterial infections. Haemophilus influenza and pneumococcus being the big 2. Many of them had a diagnosis we don't even talk about today, occult bacteremia, which was usually pneumococcus number 1 or Hib number 2, high fever, nothing else, just fever, no localizing signs. But that occult bacteremia could move into sepsis or meningitis. And we saw a lot of sepsis and a lot of meningitis too. So that's why we had to practice in a different way. We had to do many, many blood cultures, many spinal taps, and we just had a whole protocol to manage fever that's different than today.
Yeah. What did that protocol look like back then?
So the protocol back then was, if we look by age groups, that's the easiest way to do it. Birth to 2 months, if they had any temp 100.4 or higher, automatic full sepsis workup and admission. Now that's birth to usually to 1 month, but then it was birth to 2 months. 2 month to 36 month of age. Here's where we get really different. And that's a big group of kids who come to ERs with fever. 2 months to 36 months, most of them got a full sepsis workup and admission to the hospital. So we were running blood cultures, spinal taps.
I can't imagine that. Yeah, if I thought about every kid, that's almost every kid that comes to the ER.
Right. So many come with fever. Now, of course,
we don't have enough beds.
And this was the fever with no localizing signs. So no otitis, no cellulitis, no UTI. That you don't see on exam, but we would always do a UA and urine culture. No colitis, no pneumonia, just fever.
So no obvious
source. No obvious source. From 2 to 36 months, looking at that group, I'm going to break it down into 3 groups because I would say it would not be correct to say that every single 2 to 36-month-old got an LP, but most of them did. 2 to 12 months, they all got the full sepsis workup and admission for IV antibiotics. 12 to 24 months, most of them got the full sepsis workup and admission. But we started using our clinical judgment, if they really, really, really looked great, just looked like a rose, 18 to 24 month, we might not do the whole workup. And then 24 to 36 month, that was the group where we really used clinical judgment, and the protocol was more just CBC, blood culture, UA, urine culture. If the initial labs came back normal, we did not have those inflammatory markers, or the procalcitonin then. But if the CBC, if the white count came back normal, and if the UA came back normal, and the child looked wonderful, we might send him home with or without a shot of IM ceftriaxone, depending on the kid.
To like follow up in 24 hours?
Yeah, and then follow up in 24 hours if we really felt confident that they would be back in 24 hours. But some of them, if that white count came back 17,000, if the child got really irritable, we would do the LP and admit.
So from an inpatient standpoint, you got your blood, urine, CSF cultures. You started them on empiric antibiotics. They got admitted pending cultures. Is that?
Pending cultures. And they would stay on the IV antibiotics for 72 hours. And if all the cultures were back normal, negative, at 72, they could go home.
In your experience, as we developed all this amazing viral testing that we have now, when you look, we just last month did the podcast on 3 to 36 months. So an obvious source, includes all the things that you said, but it also includes an easily identifiable viral illness. So you're there with less than 48 hours of fever. It's not super high and you have croup. I can say I have an obvious source in that regard.
Right.
Tell me how, do you think that that's in part plays a part, that and the development of these really good inflammatory markers? How did that landscape?
Yeah, I think that really plays a big role. We did not have those rapid viral tests then at all. We did not have procalcitonin and CRP. And I've read things that say if a baby's procalcitonin and CRP and the ANC are normal, their chance of an invasive bacterial infection is like less than 0.5%. It's not zero, but it's very, very low.
Right.
But we didn't have that then. We did see kids sniffling, and our gut feeling was this is probably viral, but that was never part of the protocol because they can have both at the same time. You can have sepsis and a viral URI. I've seen kids who have two things, strep throat and influenza at the same time.
100%.
Yeah.
I think we take for granted how amazing our testing is today.
Yes.
Not to mention the fact, of course, vaccine coverage, which is what we're talking about today. All right. So you did a lot of this workup. I'm sure you probably do the best LP in town.
I don't know about that, but I thought in one of your podcasts, you said you like them lying, doing them with the child. Like them sitting up. That's how I liked it.
Yep.
Yeah, that's.
Did you? What do you have any tips for LPs, successful LPs?
No, I think yours were great on your podcast, but I always liked them sitting up better. I mean, and it's been many years since I've had to do them because once the hospitalists came on the scene, then I did all outpatient work, but I sure did a lot back in the 80s and 90s.
So, Meg, let's talk about Haemophilus influenza type B in particular.
Oh.
You shared with me some really amazing experiences that you had during your residency and early career. And then you kind of watched it vanish in the population, which is so cool to hear about. So tell me about those early experiences you had.
Yes. Haemophilus influenza type B, or H-flu, or Hib, it was called all of the above, was very, very prevalent when in the 80s when I was a resident. It was the number one cause of meningitis, the number two cause of occult bacteremia, and we saw it every ER shift practically in young children. And meningitis from H-flu was common and it was very severe. About 3 to 6% of the children would die if they had meningitis, and about 10 to 20% would have neurologic sequelae. So what we would see is a baby, the peak age was 6 to 18 months, would come into the ER with the parent would say they suddenly developed a high fever. It was usually a very sudden onset. They usually looked very toxic and they were getting worse quickly. And you can think of Hib as two main groups. Number one is just fever. That's your occult bacteremia. And number two was Hib with some localizing signs, and that's what was called focal invasive Hib infection. And those were very interesting, some of those.
So what were you seeing?
So very commonly periorbital cellulitis and buccal cellulitis. Periorbital cellulitis, I know it's still seen today, but H flu, periorbital cellulitis was a whole different ballgame. We could look across the ER and see that child coming in because it was so obvious. They would have all the way around one eye. It would be bright red with a purple kind of violaceous hue to it. So it was a different color than periorbital cellulitis is today. It would go all the way around the eye. There was swelling, tenderness, and a high fever and looking very toxic. They really looked sicker than kids with periorbital cellulitis do today. And when we saw that child across the room, we knew we had to be fast. Blood culture, spinal tap, and IV antibiotics. They were all admitted because most of them had bacteremia and some went on to meningitis.
Yeah, and that's incredibly interesting because that's so different than our management now.
Yeah.
Obviously, we're probably dealing with different bacteria. Sorry, I have a little cold this month. But I imagine when you call it periorbital cellulitis, you mean like a preseptal.
Yes, preseptal.
And
that is the term.
I'm sending these kids home, like that's
right.
When I think about this, like moving into an era of unvaccinated children, this would dramatically change how we take care of these kids.
Yes. I remember around the year 2000 when Hib had dropped down to just minuscule levels because the vaccine came out in 85. The better vaccine, the conjugate, came out in 87. So by 2000, we were rarely seeing Hib disease anymore. But when I saw a patient with, now it's called preseptal cellulitis, back then we called it periorbital cellulitis, my gut feeling would be LP, admit. And I'd have to remind myself, no, this is not Hib. It's not a hematogenous spread. With the periorbital cellulitis we see now, it's a contiguous spread, like from a bug bite, sinusitis. And it doesn't need to be, most of the time, does not need to be admitted.
Yeah. And it's interesting. I have a colleague that's been doing this for 25 years, and we were talking about preseptal cellulitis, and she said, it's interesting to me that you're so comfortable sending them home. I generally admit those patients. And I thought, and it really wasn't until I read about this that it occurred to me that that's how it was at one time, right? And I am just a newer provider, and I am only functioning on the way we do it now.
Right.
So I don't have that to fall back on. I thought the buccal cellulitis was really interesting because I had never heard of it before you mentioned it to me. What does this look like?
So buccal cellulitis was pretty common also, and it looked like a child would come in, usually young children, babies and toddlers, preschoolers, with a red cheek, very red with that violaceous hue, just like the periorbital. And it was swollen, hot, tender, and the child had a fever and was very ill appearing. And it was that same mechanism where there was hematogenous spread of the H flu to go and seed the dermal vessels under the cheek. And that gave that red-purple color. And again, we had to rush, do the blood culture. I'll never forget, one time I was in the emergency department taking care of a child. It was very clear that this toddler had buccal cellulitis, classic red-purple cheek, classic high fever. I had done the blood culture, done the lumbar puncture, was getting going on IV ceftriaxone, and suddenly the child started having seizures, tonic-clonic seizures. And about that time, the nurse came in with the lab slip. Back then, everything was on a piece of paper. And the lab slip had a CSF gram stain that was H flu, gram-negative coccobacilli. And so this kiddo had buccal cellulitis and meningitis.
Yeah, that's frightening.
Yeah.
But I think the big take home for clinicians here is, this is something that we probably have never seen, but if you see this, and you're trying to risk stratify what this is, it's so important to ask about their vaccination status as we move into this kind of new age of medicine.
Yes.
So we can figure out if we need to be more concerned, right? Maybe this patient needs an LP. Maybe they need antibiotics pretty quickly, and we need to admit them to the hospital.
Right. Absolutely.
So, really interesting. And then you talked a little bit about like how they present with a septic joint
hmm And that was a little less common, but sometimes they had a septic joint. It was usually the hip in a toddler. And same thing, the fever, very irritable. That just went along with Hib or pneumococcus. But they just really looked sick and would have a septic joint. And the blood culture was usually positive. Osteomyelitis was possible too. But we haven't gotten yet to the biggest Hib fear that every ER provider had a fear of, and that was epiglottitis.
Yeah, we're all still very afraid of that. We just haven't all seen it. So, which kind of makes it more scary, I think. At least you can tell us what to look for, because I mean, I've seen it once, but it was an adult, and it was kind of a bizarre case a long, long time ago when I was a paramedic. So, but yeah, talk to us about that.
It was, and I must say, I didn't see it as often as I saw occult bacteremia from Hib, sepsis, meningitis. Those were more common. A lot of meningitis, periorbital cellulitis. But I saw 3 or 4 cases as a resident, and we would see the child drooling, anxious, sitting in tripod, bent over and bracing themselves on their hands if they were on the exam table. If they were in mom's lap, they would be leaning forward, a neck extended, the chin thrust forward. And all of those things the child was doing were to open up the airway. When the chin is thrust forward, that'll pull the tongue and the swollen epiglottis away from the airway. When the neck is extended, that'll open up the pharyngeal airway. So the child, without realizing it, was doing things to try to help keep their airway open. And our attendings, when I was a resident, just drilled into our head, do not get that child upset. Do not put an IV in. Do not put a tongue blade in their mouth ever to try to look in their throat. That is a medical emergency. When you see it, you just tell the mother, or father, whoever's holding the child, hold the child upright. Don't let them lie back, because if they lie back supine, the swollen epiglottis can move back and block the airway. Then we would rush and get anesthesia or ENT, and they would take the child to the operating room for intubation in a controlled setting.
Okay. And I'm sure we would call anesthesia because we don't have in-house ENT. So we would, but good thought to maybe even do it in the operating room.
Right. And I, for 20 plus years, I've not seen a single case. Nowadays, there are fewer than 100 cases a year. Before the Hib vaccine, there were 10,000 to 15,000 cases a year. And now less than 100. It's just incredible.
I'm not sure I understood that it was Hib driven.
Yeah, in children, about 75 to 90% were caused by Hib. Now that Hib is close to gone, not completely gone, but close, there are other, I think strep can cause it. There's other organisms that can cause it. And in fact, I read something that surprised me that said more adults get epiglottitis now than children. And you mentioned you had seen it in an adult. Yeah. That's interesting.
Yeah. And she did all the same things that you described. And that was and it really, I'm not sure. This was a long time ago, so I can't even tell you if it was what I was thinking, but I remember the hospital telling me afterwards, but it was a tripoding, acute distress, all those things.
Yeah.
Yeah. Fascinating how things have changed. Talk to us a little bit about how you have watched the landscape change, how it's evolved with the vaccine.
With Hib in particular?
Yeah.
Amazing. Like to go from seeing periorbital cellulitis so frequently to preseptal cellulitis, that's a whole different ball game, not the high fever, not the toxic, not the bacteremia, to go from seeing so many cases of meningitis to hardly seeing any. I think the residents now do far fewer lumbar punctures on children than we did back in my day. In my day, it was easy. And I'm not one who's great with her hands and doing procedures, but I was good at lumbar punctures because we had to do them so frequently.
You did them all the time.
Yeah, it's just a whole different ball game. And then we're seeing fewer children with the sequelae. Like I remember when I was a resident in the late 80s, I had a continuity clinic patient who had had pneumococcal meningitis as a toddler 4 or 5 years prior, and she was completely deaf. She lived, she made it through her meningitis, but she was completely deaf. And pneumococcus is the number one cause of deafness with meningitis. And I had to help, tried to help her get hearing aids, tried to help her get more aid from her school for the hearing impaired students because there were no cochlear implants back then. So,
yeah, I think we get complacent because we haven't seen this, and that's what's so valuable about hearing about your experience because
yeah,
I've not lived through this, right? And we have these generations of vaccination, and so we're not seeing it, and we just like forget what this looks like. And it's not just life and death. It can be, are you going to have a developmental delay? Are you going to have deafness? Are you going to have other
right.
problems as a result of these illnesses? So important. I've said this before, and I'm going to say it to you again. You need to write a book about this. And not just for providers. I mean, I think that's incredibly valuable, but also for parents that, are on the fence, right? Like, I mean, if you don't know what it's like before and after, I think these are really valuable experiences to help people make good decisions. So,
yes.
Okay, let's talk about streptococcus. You've mentioned this, strep pneumoniae. I just had a kid with strep pneumoniae bacterial meningitis just a few weeks ago. But, when we talk about vaccines, at least in my practice, we ask parents, are your children vaccinated? And if they're young, I will drill them down on, have you gotten your 2, 4, 6-month vaccines? Because these are the two big bad bacteria, as I describe them, that like to kill kids. And so it's important to me to know that you've gotten your Hib and your Prevnar that are going to cover these two bacteria. So tell us about what your experience looked like.
So pneumococcal infections we saw very, very frequently also, just like Hib. Those were the two big bad bugs in the 80s. And pneumococcal into the 90s because there was no vaccination for it until 2000. That was the first Prevnar. Pneumococcal did not drop as amazingly well as Hib did because it's harder for a number of reasons. There are more serotypes. Pneumococcus there can be asymptomatic carriage in the nose, and you don't have that as much with Hib. So for a lot of reasons, it's harder to completely get rid of pneumococcus. As you said, you had a patient with pneumococcal meningitis, but it went way downhill after the vaccinations. And we would see, very similar to what I described for Hib, a baby or toddler or preschooler, usually babies and toddlers, coming in with high fever, very irritable, not eating well, lethargic, sometimes vomiting. Pneumococcus tends to have a higher white count. And sometimes the residents would have a little vote or bet on, do you think it's going to be pneumococcus or Hib before the cultures came back? And if the white count is super high, then more often it was pneumococcus.
It's pretty amazing that to hear you talk about the culture coming back because I can order a meningitis encephalitis panel and have it back in an hour.
Incredible. We didn't have that then.
Yeah, it's pretty amazing what tools we've gotten. So it's cool. Yeah, so it sounds like a lot of the things that we still look for with regard to risk stratifying children for meningitis, we're looking for that change in mentation. And I think for little babies, that's so hard, right? Because they're not talking.
Yes.
But I lean a lot on parents. Was that kind of one of your techniques?
Absolutely. Always in pediatrics, you lean on the parents. They know, a change in their child. Absolutely. But you're right. In a baby, change in mentation can be hard to tell. They can't talk. You can't.
What's that mean?
Right. They don't have nuchal rigidity usually. I mean, sometimes, but not usually. So you can't say, oh, is your neck stiff? So really, sometimes fever was the only symptom. Thus, the many LPs and the many admissions back in that day.
Yeah. And I think, and to err on the side of caution, if you're concerned about some of these things, you do the LP so that we can sleep at night. Right. The kid I saw just a few weeks ago couldn't lay flat. And in this case there was also some concern about the abdomen, but I think at the end of the day, the child was just very uncomfortable flat. And so that was not normal for this kid and looked very fussy. And so once I was able to get the baby kind of up in mom's arms, baby was more comfortable. And I was like, that's weird. I can't tell you how important it is to listen to a parent that says, this is not my kid.
Yes.
Because every time a mom has said that to me, there's been something wrong with that kid.
Yes.
So yeah.
Moms know. Yes.
They do. They do. Okay, well, let's move into measles. I'm really excited to pick your brain on this one because it's here, and and you've seen tons of this.
It is,
and it's on all of our minds right now. So, what was it like working in a measles epidemic?
It was something. I had never ever seen a case until my last year of residency. I had the measles vaccination in the 60s. In the 60s, they had the separate measles, mumps, and rubella. And then in about 1971, I believe, the MMR came out. So I was protected. My friends were protected. I never saw a case. Med school, I never saw a case. First and second year residency, never saw a case. Then suddenly, my third year, we were seeing all these children coming in. It was in New York City, Babies Hospital, with high fever, irritable, and what we called the 3 C's. And that was cough, coryza, and conjunctivitis. And that was in the prodrome. And you might think, well, how did you know it was measles?
Right.
Well, why not some other virus? Lots of viruses cause cough, coryza, and say adenovirus, you might have conjunctivitis. But in that prodrome, they would often have Koplik spots. And those are little whitish gray spots on the buccal mucosa right across from the molars. And then we knew it's measles.
And you were talking to me about how that's kind of an early finding.
Yes. It goes away. The Koplik spots go away when it moves into the rash stage. So you have about the first 3 or 4 days is the prodrome, no rash. That's when it can be a little harder to tell it's measles, but if you have that the Koplik spots, it's obvious. Then the rash would come, and it was a very remarkable rash because it was bright red, maculopapular, but confluent. It would they would all coalesce together, starting at the head, face, behind the ears, and then moving down the body, covering every part of the body except usually sparing the palms and soles.
Okay.
Yeah.
And you'd see this rash, and you were like, I know, this is measles.
Yes. Yes, especially when there were tons of cases coming in. But it really was much redder than a typical viral exanthem and just so confluent, covering so much of the body.
Yeah. Okay. Yeah, I guess that would be your typical viral rash is a little bit more like scant.
Yeah.
So, yeah, good markers to look for. I think it's great. And, I was telling you this earlier, like, I don't look for Koplik spots. That's not something that I routinely do on my exam. But as we, kind of move into this era where it's out there and could certainly be affecting our kids, we'll have to think about that when we do these exams.
Yes, absolutely.
So
absolutely.
if I'm thinking adeno, because your eyes are red and leaky, I need to be looking in the mouth better.
Right.
Yeah. Tell me again what they look like.
They're small, white to kind of grayish. Textbooks say grayish blue, but I never appreciated any blue color to them. But small whitish gray spot right on the buccal mucosa with red around it, kind of like a red halo around it, real small.
And if I'm looking in there, I'm going to see it. Like it's not something I'm going to, is there not subtle?
Yes. It's small, but you have to look for it. And, measles has been down for so long. I don't recall ever seeing a case in Missouri. I know there have been some, but not in my hospital or not in my practice. The last time I saw a case, let's put it this way, it was probably early 90s. Yeah.
Okay. And when you look in there, you're going to have lots of spots in your mouth?
No, just a few.
No.
Just a few.
Okay.
And
way up at the
usually
top.
Across from the upper molars. They can be across from the lower molars, but usually it was across from the upper molars on the buccal mucosa.
Okay.
Yeah.
So you mentioned early in your residency, you weren't seeing any measles. And then you guys had this huge epidemic and you were seeing tons of measles. Yet we were already vaccinating with the MMR. What was causing that to happen?
Well, we were wondering that. And the scientists found out at that time that there was an entity called primary vaccine failure. And that is where about 2 to 5% of people don't have an immune response to their primary MMR, their first MMR. So people were getting a measles vaccine from the 60s, 1963 on. So that's almost 30 years to 89 to 90, where some people would think they were fully protected because they had the vaccine, but they really didn't make any antibodies at all. And that number, obviously, year after year would get bigger and bigger. And then the thought is that the epicenter of the 89 to 90 outbreak was New York City. And probably a traveler from another country who had measles came in to New York City. And so many people at that point were not immune, even though they had had the vaccine because of that primary, vaccine failure. So then they started getting it. And it spread to many other states. But New York was the worst because there were other factors too, like people living very closely,
Sure.
close together in tenements, immigrant families who had just come over from Dominican Republic or Puerto Rico and had not been able to get their children vaccinated yet. So a lot of reasons that it just spread like wildfire back then.
Yeah, it's interesting. I remember I must have been in that age group where you got one MMR, because I remember when I went to high school, I had to get a second MMR and I was irritated by it. But now, like, for good reason,
Yes,
right?
and that second one, that was the whole reason. The second one was instituted in 1990 because of that 89 to 90 outbreak with around 55,000 cases in the United States. So that second one was instituted. People call it the kindergarten MMR. I always gave it at 4 years of age, but it can be anywhere from 4 to 6. And with that, the numbers plummeted. By 2000, it was pronounced that measles had been eliminated. But eliminated doesn't mean gone or extinguished. It means the endemic state has been eliminated. It's not transmitting freely. In other words, it needs an outside source to bring it back in.
So something to think about if you've got a kid in that age group that doesn't have that second one, right? They could have a vaccine failure with round one.
Right.
And really have no immunity.
Right. That's why it's so important to have two and to have school regulations that say to go to kindergarten, you need to have the two.
A lot of talk in the news right now. Measles is a mild illness. I'm thinking medicine, we don't think that, but like I hear it on the news and I'm like, oh my God. So let's talk about what the complications of measles look like.
Okay. So one of the biggest is pneumonia. And usually if I was admitting a child, and I'd say 1 in 4 or so have to be admitted. Some of the Texas data from 2025, 1 in 3 were being admitted. It's usually pneumonia or dehydration. There's otitis as a complication, encephalitis. That famous author of Charlie and the Chocolate Factory, Roald Dahl, his daughter died of measles encephalitis. She had it 1 year before the vaccine came out. So it's real. It's rare, but it's real. Pneumonia, though, is the real bad one. And I would say almost every patient I had, if they had measles and they had pneumonia, they were admitted to the hospital. The pneumonia just was usually worse than a typical pneumonia.
Okay. So let's talk about chickenpox or varicella.
Okay.
I got chickenpox as a kid.
Me too.
And yeah, they offered my kids the vaccine and I was like, shouldn't you just get it? But then you can't get it because people were getting vaccinated. It's just not even out there. So ultimately, my kids got vaccinated. But I feel like this is frequently underestimated. So talk to me about what your experience is. Literally, the last time I saw this, I was 13 and I had it myself. So
I had it
at
16. And I always remember the year the vaccine came out because it was the year my youngest son, David, was born, 95. The vaccine came out. So my 2 older children had the disease because there was no vaccine. So chickenpox, it was usually a mild disease, but sometimes not. The mild disease, there's a prodrome, low fever, and malaise. Sometimes the real little kids don't even have that at all. Then you have the rash with 3 stages. The first stage is pink maculopapular. Stage 2 is vesicles. We always called it dewdrop on a rose appearance. So they're a little bit bigger of a vesicle than like a Coxsackie vesicle.
That's what I was just going to
ask. And a little more look like they have clear water in them, but they're not a big juicy bulla, so small vesicles. Then stage 3 is crusting over. And the key thing to know it's chickenpox is you have to have multiple stages at the same time. So because you're going to have your stage 1 maculopapular, then a couple days later, those move into stage 2, but on a different part of the body, you're getting new stage 1 lesions. Then some move to stage 3. They go through all the stages. So, a few days into it, you're going to have all 3 stages on the body. And if a kid has only the pink maculopapular spots and it doesn't progress, then it's not varicella.
And how early in the course of illness does the rash show up?
Pretty quickly after a day or two, usually. And that's, if they have the prodrome. Sometimes with young kids, there's no prodrome. So the mom doesn't know they're sick until the rash comes.
Yeah. So did you have kids that came in kind of early and you were like, well, it could be chickenpox. Let's watch.
If they come when there's only a few maculopapular spots, then yes. Sometimes it wasn't absolutely clear. And I always told the residents, follow up is our friend, following up, whether it's by phone or having them come back in. And sometimes I would just call people the next day and then they'd say, oh yeah, now they're getting a little water blister. And then like, there's our answer.
Now we know. Yeah. When's the last time you saw chickenpox?
Last time, probably 2005, if I had to guess.
Okay. Long time.
Long time.
Yeah.
Long time. But it also is not completely gone, and there are complications. When the shot first came out, many moms, just like you said, you weren't sure, do I really need to rush and do this shot, this vaccine?
Mm-hmm.
I mean, it's a mild disease. It's an annoyance for most kids, but not super severe. So we had a lot of parents initially not want to get the shot. In fact, Toni, have you heard of chickenpox parties?
Yeah. That was my plan. Like, I'm going to get it. I'm going to take my kids over
take
here.
them to a neighbor's house. And people would do that so that hoping their kid would just get it and get it over with. But then as pediatricians, we saw more and more complications. I mean, every year I had to admit at least a kid or two for complications. Then we thought, why take that risk when it's so easily preventable? Yeah. I had one very remarkable complication, if you want to hear that story.
Yeah.
I was ward attending. We had a little girl come in, probably early school age, and she had chickenpox with a cellulitis. That was a common reason for admission if they had a bad cellulitis around the lesion. So we started her on IV antibiotics to cover staph and strep. She seemed to be getting better. The redness, of the cellulitis went down. The fever went away. We were like, oh, maybe we can discharge soon. And then suddenly she got way worse. High fever, chills, shaking chills, malaise, and a new heart murmur. So I'll never forget this. We did, the blood culture showed Staph aureus in the blood. So it had moved from the cellulitis into the bloodstream. And then the echocardiogram showed vegetations on the tricuspid valve.
Oh,
and
no.
so that staph had seeded the tricuspid valve. And the child, her tricuspid regurgitation was so severe, she had to have open heart surgery.
Wow.
And I didn't mention the most important part of the story. She had not been vaccinated. It was after the era. She could have been, but she was not vaccinated. And it could have been prevented.
And that's just it. You roll the dice, right? You could not vaccinate and get it and have a poor outcome. It might be mild, right? Or, it might not be, and you can't predict when that's going to be. Do you think that is because chickenpox, you're just so pruritic, you're just so itchy?
Yes.
Is that why you saw more of the skin involvement with that particular virus?
I think so, because people were scratching so much. I forgot to mention that. Thank you, Toni. It's extremely itchy. I mean, probably the itchiest things are scabies and chickenpox and eczema. It was so itchy. So then they'd scratch, and that, could have a little micro opening of the skin and, open that.
Or 10,000 of them.
Yeah.
Gee, I remember having chickenpox and itching. Do you remember that?
I do. And calamine lotion back in the day when
oatmeal
in the
baths and
70s. And yep.
all the things. I don't remember any oral medicine my mom gave me. It was
Yeah.
just a lot of calamine lotion and oatmeal baths. And,
Right.
I think at one point she told me to wear gloves because I was scratching so
Uh-huh.
much.
Uh-huh. Right. Most people though don't have the complications, but some do. And that's and another thing, speaking of complications, is if a pregnant woman gets chickenpox. It can be there's a whole syndrome if they get it early in pregnancy where the baby has scarring, eye problems, brain, CNS problems. Then there's another issue if the mother gets it right before delivery.
Mhm.
And that's called perinatal, or sometimes it's called neonatal varicella. If they get chickenpox 5 days before delivery to 2 days after delivery, the baby, there's a very high mortality if they don't get VZIG right away. The baby's covered with vesicles, fever, myocarditis.
Yeah, it's pretty incredible how a lot of these like benign childhood illnesses really do damage in pregnant women and the fetus. It's really
Yes,
scary.
yeah,
Yeah. All right. Yay for vaccines.
yay for vaccines.
Right.
Yes.
Okay. Well, last, let's talk about rotavirus. I think, I haven't seen very much of this in a long time. My kid got it when he was, I think, 18 months old.
Mhm.
I remember the diarrhea was just incredible. And we were so close to taking him to the ER. Thank God my best friend was a nurse and said, give him chocolate milk. That's what he liked to drink. And that was a time in the world where we didn't let you have milk when you had a gastrointestinal virus. And so I hadn't given it to him, and that saved us.
Yeah.
But yeah, tell us about your experience with rotavirus.
So rotavirus, you remember that diarrhea? We saw so many cases, so many, and often they had to be admitted. There was a lot more fluid loss than with norovirus. To me, I always think of that as newer because I remember rota so well. But rotavirus was often in the winter, and it would start with low fever and vomiting. It did not start with diarrhea. Usually it started with vomiting, intense vomiting, but for a short period. Then it would move into the diarrhea. And you never forget rotavirus diarrhea when you've seen it. Greenish, watery, huge, fill the diaper kind of stools. Constant.
Yeah.
10 a day plus. And so many kids would come to the ER and they would be dehydrated, metabolic acidosis. The little babies would sometimes have a low glucose too, and they would have to be admitted.
And we see that now, norovirus, like you mentioned, sapovirus, and these other mega diarrhea causing illnesses. But I literally cannot, I don't think I've had a kid test positive for rotavirus in my entire peds career.
Wow.
So
Yeah. The vaccine just did an amazing job. The 2006, the vaccine came out. There was one that came out earlier and didn't do well and was taken off the market. That was like 8 years prior, taken off the market. And then they had to work for 8 more years. And then they got in 2006, the Rotatech. And we hardly see it anymore.
Yeah. Incredible.
Yeah.
Okay. Well, I can't thank you enough for being with us here today.
Oh, sir.
Yeah.
I've enjoyed it.
Good. And I'd love to have you back. We should brainstorm about another one we can do in the future. After a lifetime of taking care of children, and what would be your words of advice for new clinicians that are practicing in pediatrics?
I would advise them to do several things, 3 main things. Number 1, really listen to the parents, because when a parent says they're worried about something, their gut feeling is usually correct. Number 2, look at the child and use all of your knowledge and clinical judgment as well as the written protocols in assessing the child. And number 3 is to be ready to educate parents about vaccines and about vaccine-preventable diseases. Be ready and take the time to answer their questions. These younger parents have never seen some of these diseases, so they think the diseases are gone and that the vaccine is just a risk to their child. We need to explain to them that they're not gone. Measles is a great example there. And measles may be the canary in the coal mine. It's so contagious that as vaccine rates go down, measles goes up first. But if vaccine rates keep dropping, we may start seeing more Hib, more rotavirus, more pneumococcal meningitis. So educating parents is key, and that because parents really do want to protect their children. So that's something I would say to new providers.
Yes, awesome. The best thing you could have possibly said. Yeah. And I think as providers, we take it for granted too, because we haven't seen it. So that's why I think your experience is so valuable. You better believe when I start seeing these things, I'm going to call you.
Okay, feel free.
Like, you're not going to believe what I just saw today. Well, absolute pleasure having you on today, Meg. Thank you so much.
Thank you, Toni. I enjoyed it. Thank you so much.
All right, take care.
Take care.
Thanks for joining me and Dr. Wang today for this discussion on vaccine-preventable illnesses. Now join us here on PemChat next month when Dr. Murphy comes back for Murphy's Mystery Monday. It's an episode all about interesting pediatric cases. We'll see you then. Any opinions expressed on today's podcast are solely those of the speaker and do not reflect the opinions or policies of any employer or hospital system. In many states, advanced practice providers work collaboratively with physicians. One should always be careful to consult with your physician leader when it's appropriate. This podcast was designed for medical education purposes only. Its speakers have made every effort to provide the most current and evidence-based information. However, that should never replace one's own effort to validate current evidence-based practice before implementing a plan of care. Any pathway or algorithm that we may have discussed may not reflect those of your healthcare system. Please be aware that these may change based on your geographic location or current employer site. This podcast was not designed in any way to provide medical advice or treatment plans for patients and their families. If you have a medical concern or an emergency, please be seen by a local medical provider or call 911 for assistance.